Okay, doctor, you can start your case presentation.
Okay, then. The 75-year-old male, Mr. Selamuthu from Ramnath, who is a farmer by occupation, belonging to socioeconomic class 4, who comes to the OPD with the chief complaints of ulcer in the left undersurface of tongue for 1 month and pain at the site of ulcer for 10 days.
Okay, ma. What are the chief complaints the patient will get for oral cavity malignancy?
In ulcer like lesions, pain, a dysphagia, change in the voice, um, difficulty to protrusion of tongue.
Okay. The chief complaints would be a chronic
Salivation.
non-healing ulcer. Okay. Most of the time that will be the presentation. Chronic non-healing ulcer. Okay. So number one is chronic non-healing ulcer. Number two is ulcerative growth. Number three is ulcerative proliferative growth. Ulceroproliferative growth. Okay.
Okay, sir.
Then the other complaints like excessive salivation and everything will come. Okay.
Okay, sir. Rahul? History of presenting illness. The patient was apparently normal 1 month back, after which he noticed an ulcer in the left undersurface of tongue present for 1 month. 1 month insidious in onset, started as a small ulcer and gradually progressed in size to reach the present size, not associated with the discharge. History of pain. Present for 10 days at the site of ulcer, which is insidious in onset, progressive, dull aching, continuous pain, non-radiating and not referred to here, aggravated by speech and food intake. Not There is no revealing factors. Hello, sir.
Yes, ma. Proceed.
History of excessive salivation present, history of foul smelling, history of difficulty in speech, history of dysphagia, history of difficulty in tongue protrusion and mobility, history of loss of appetite and loss of weight, no history of difficulty in opening in mouth, no history of hoarseness of voice, no history of any trauma, no history of evening rise of temperature, no history of tobacco and betel nut chewing, no history of neck swelling, no history of swelling elsewhere in the body.
Okay, ma. According to the tongue, uh, what history is more important to ask in these histories? Excessive salivation, foul smell, difficulty in speech. Among those, no, which is more important to ask, which you should not forget to ask.
Mobility, sir.
Okay, very good. Then
Dysphagia and protrusion.
yes, okay. Dysphagia. Okay, it is also important. Okay, then.
Salivation, foul smelling.
Okay. Why the excessive salivation will be there?
Because of the restricted tongue mobility, the patient will swallow less amount of saliva, sir. So there will be excessive salivation.
Yes, the patient is not able to swallow the saliva, so the patient salivation will come through the angle of the mouth. So the what the clinical DAS is telling is that the patient is typically sitting in the OPD with the handkerchief in the around the side of the mouth. Okay, I am agree with some important history. You should ask regarding tongue malignancy, because today you are going to present carcinoma tongue. No. So among those, which is more important, you should not forget to ask.
Sharp tooth.
Sharp tooth, yes, very good. I agree with you. The history of sharp tooth is very important, because the teeth will cause injury and cause ulcer, a non-healing ulcer. Okay, then history of removal of
smoking, alcohol.
Yes, history of that those things you will ask in the personal history. Sharp tooth excision, that's all thing you will ask in the past history. What is history of altered voice is very important regarding tongue. Why? Because see, the posterior tongue, posterior 1/3 growth, you are not able to see the lesion properly. Okay, the patient will not see the lesion properly. Okay, so the patient have only complaint is the change of voice. Okay. So
Okay.
the posterior third tongue malignancy will not show any inspectory findings to the patient, both also for clinical examiner. Okay, they have the chief complaint only altered voice. Okay, that's
Okay,
very
sir.
important. Okay? Then the hoarseness of voice. Hoarseness of voice is when it will come.
Then the laryngeal nerve is damaged, sir.
Not damaged. The malignant infiltration occurs to the laryngeal nerve. The patient may get hoarseness of voice. Okay. Okay, ma'am.
From a past history, no history of similar complaints in the past, no history of tuberculosis, bronchial asthma, epilepsy, diabetes mellitus, hypertension, and jaundice, no history of tooth extraction with delayed healing, no history of ill-fitting dentures, no history of any sexually transmitted diseases, no history of chronic drug intake, no history of previous surgeries.
Okay, and among the past history, go to the previous slide. Okay, no history of tooth extraction with delayed healing. Okay, also you have to tell one more important point regarding oral cavity malignancy regarding the tooth. What you will do? What you will tell? One important point you have to tell. Go to the previous. Go to the previous slide. Here, you may be written. I may be missed to see. Previous slide.
Rahul.
Yeah, yeah. So history of fall of teeth,
Okay.
spontaneous falling of teeth. Why it's important? History of spontaneous falling of teeth, or the patient may told us, sir, this tooth was loosening, then I removed it, like that. What it is important to say? What is that? Why we
Due
have to
to
those history? Yes.
carcinoma infiltration to alveolus or floor of the mouth.
Yes, very good. The carcinoma infiltrated to the alveolus, so that causes loosening of the tooth. So it may be the teeth may be spontaneously lost, or the tooth is loosened. The patient himself may be removed. Yes. So among this oral cavity malignancy, you told all these things. One more history you should ask. Go to the previous slide. Go to the previous slide. One more history you have to ask. No history of trauma, no history of everything you have asked, no history of one more history you have told that no
Spicy
history.
food items.
What, ma?
Spicy food items intake.
Okay, very good. That you will ask in that personal history. Okay, no problem. Or you can tell here itself. Okay, no problem. You ask. No history of tobacco or betel nut swelling. One more important history you must ask.
See,
Okay.
betel.
Yes, yes. Okay, let me see. You are telling in the personal history, or otherwise I will tell. Okay, you go to see.
Okay. Personal history. Smoker for the past 40 years. Smokes 3 BD per day. Number of packets is 6. Consumes alcohol for the past 40 years occasionally. History of spicy food intake present. No history of tobacco or betel nut chewing or normal bowel and bladder habits.
Okay.
Family history.
In the personal history, you have told about that smokers of for the past. In the smoking, you have to keep in your mind two important points. Okay. One important point is you have to ask the history of reverse smoking. Do you know what is reverse smoking? Usually the Rajnikant will do no. The burning point will be he kept inside the mouth.
Oh, okay.
Because he will keep inside the mouth, and then he will take the cigar from that floor of the mouth, or from the hard palate to the outside. Okay, so that
Okay.
reverse smoking is more riskier than the normal smoking.
Okay, sir.
Okay, so you have to ask in oral cavity malignancy. You must ask that the history of any reverse smoking. Okay.
Okay, sir.
Okay.
Family history, no significant family history, sir. General examination. The patient is conscious, oriented, moderately built, and moderately nourished. No pallor, no icterus, cyanosis, fetal edema, generally lymphadenopathy. Grade 2 clubbing is present. Halitosis is present, and drooling of saliva is present, sir.
Why this patient is having clubbing, grade 2 clubbing? Pravina,
Sir, sir, sir.
why this patient is having grade 2 clubbing?
Today, metastasis, sir.
No, the patient is a smoker, chronic smoker. You have told no. Go to the previous
Yes,
slide.
sir. Yes, sir, yes, sir.
Yeah, smokers for the past 40 years smokes 3 PD per day. Okay. So
Okay,
the
sir.
number of pack years is 6. Okay. Number of pack.
Okay, sir.
What is number of pack years? 6. Number of pack. Oh, it's not look relevant. What is number of pack years? What is smoking index?
Sir, number of cigarette smokes per day, sir.
Number of number of
An amount of cigarettes a person smokes for his life, long period of time, sir.
smoking index means
That is the number of packs of cigarettes smoked per day by the number of years the person has smoked.
yes, that is called a smoking.
Correct, sir.
What is pack index? So number of cigarettes smoking and the number of years multiplied by number of years is a smoking index. What is pack index?
Okay, sir.
Number of packs smoked per day. Okay. But this
Okay, sir.
what you have written is wrong. Okay. Pack years is wrong.
Okay.
Number of pack years is wrong. Okay, you correct it.
Okay, sir.
In which case that those things are very important. Number of so smoking index or pack index, which case is more important.
Oral cancer, lung cancer.
Okay, then yes, very good, Vanita, very good. Peripheral arterial disease. Okay,
Okay, sir.
okay. Go to the previous slide. Go to the previous slide. Previous slide. Okay. So smokes. So in oral cavity malignancy, you have written everything is very nicely. Smoker for the past 40 years smokes 3 p. So do you know one important fact that oral cavity malignancy is more common in non-smoker than smoker? Do you know it?
No, sir.
Okay, actually it is more prevalently present in non-smoker than the smoker, but அது வந்து அந்த பாயிண்ட் வந்து it's not correct. Actually it is present more commonly in the smoker only, but ஆனா comparatively பாத்தீங்கன்னா non smokers will get this disease. Okay,
Okay, sir.
so data எப்படி தெரியும் பாத்தீங்கன்னா உங்களுக்கு non smoker will have more disease மாதிரி இருக்கும், but the truth is smokers will have more chance to get that malignant disease in oral cavity. Okay.
Okay, sir. Vital signs: pulse rate 76 beats per minute. It is regular rhythm, normal volume, no specific character, no radial delay or no radiofemoral delay. Pulse equal in all peripheral palpable vessels, no vessel wall thickening. BP 120 per 80 mmHg measured in the left upper arm sitting
You
position.
are telling that regular in rhythm. What is it mean regular in rhythm?
It is not irregular.
Okay, it's not irregular means it is regular. Is it? Can you explain me what is regular in rhythm?
There is no alteration, sir. It is equal.
Okay. You are telling there is no tachycardia, there is no bradycardia. Is it?
Yes, sir.
But I want that medical explanation answer. What is your regular rhythm means here? What is it is as in sinus rhythm, is it?
Yes, sir.
What is the sinus? I'm asking you very easily. What is sinus rhythm? Actually, it is a medical question. But anyway, you are telling that regular rhythm frequently. That means you are telling me, sir, ask questions about rhythm, sir. Like that. Okay, that's why I'm asking you. The sinus rhythm means in that you ECG, you know, P wave followed by QRS complex. Okay.
Yes, sir.
P wave followed by QRS complex. You know, this is P wave. Okay. P wave. QRS T. Okay.
Okay, sir.
So the P, if the P wave is followed by QRS complex, means that is called sinus rhythm. Okay. Got the point? If P wave followed by not QRS complex, means there may be a heart block may be present. The patient may not have sinus rhythm. Okay.
Okay, sir. Hello.
Proceed. Proceed.
Respiratory rate 18 breaths per minute, regular in rhythm, abdominothoracic. Temperature it is safe breathing. Examination of the oral cavity. The commissures and lips are normal. Gums, alveolus, buccal mucosa are normal. Teeth, there's a diffuse staining of teeth present. Dental.
Normal shape of lip, you told, I asked in the last class itself. What is the normal shape of lip?
Sir? Hello,
Normal
sir.
shape of lip, normal shape. Normal shape of lip. Anybody in that group, you can answer. Normal shape of lip. Okay, very good. Ashika, right. Cupid's bow. Cupid's bow. Normal shape of lip. Okay,
Okay.
like this. Okay, Cupid's bow. What is it? Tamil? You know, Tamil. In Tamil, it's called Manmadan Anbu. Okay.
Okay, sir.
Okay. In the regarding the tongue, no benign condition. So for benign condition, you forget to ask one of the important history. What do you? Can you tell me what it is? For difficulty in protruding the tongue, that is the I am also giving the clue. Difficult to protrude the tongue. It means what is the benign condition you are keeping in your mind?
Um, tongue tie, yes, sir.
Just very tongue tie. Tongue tie. So the patient will tell no. Ask the patient to say Valiparam. They will say Valablam. Okay.
Yes.
Not rotate. Okay. And it is very difficult to protrude. Okay.
Sir, submucous.
Yes. Tell me.
Okay. Hello,
Yes,
sir.
ma'am. Yes, ma'am. Proceed.
Okay. Rahul? Tongue. A single ulcer of size 4 cross 3 centimeter is present in the left ventral surface of the tongue, which is irregular in shape, extending anteriorly up to the tip of the tongue and posteriorly up to first molar teeth, laterally up to the lateral margin of tongue and medially across the
What
midline.
ventral surface here, ma'am? What is in the ventral surface? Tongue.
Uh, which is close to the floor of the mouth.
Okay, it is close to the floor of the mouth is called ventral surface. And so the above the which is present is dorsal side.
Granule. Okay, so dorsal.
Okay, here The same thing you will have anatomically in that one more part also, where usually that ventral surface is which is present anteriorly, dorsal surfaces which is present actually posteriorly. You have some places you are having like a contradict like that. So in the tongue, ventral surface is, yes, very good, Ashika is good. Penis, male genitalia, the ventral surface is present actually under surface. The dorsal surface which is present in, which is we are looking anteriorly, is dorsal surface. Okay.
Okay, sir.
You got the point, Pravina, what I am telling?
Okay, sir.
Okay, proceed.
Margins are ill-defined, edges are everted, floor consists of white patches which is covered by slope. There is no discharge from the ulcer and surrounding areas appear normal. Inability to protrude the tongue. Mobility of the tongue is restricted.
Go to the previous slide, Pravina. Yes, one important thing in the examination of the oral cavity, one important point what you should commit is the hygiene of oral cavity before you are examining. Okay. Oral cavity
Okay,
is
sir.
very important because most of the disease you will get because of unhygiene practices. Corona
Okay,
also not exception for that. Okay. So oral hygiene is very important. So you are committing in that history itself one word for that. What it is?
halitosis.
Yeah, halitosis means what?
Smelling. Foul smelling, bad smelling. That's
Bad breath. Okay, very good. Okay, proceed.
inability to protrude the tongue. Mobility of the tongue is restricted in the left side. There
Okay,
is
what
deviation of tongue.
ability to protrude the tongue? Which muscle is? Uh,
For
is
protrusion, genioglossus is for protrusion of tongue.
okay. Protrusion of the tongue is the muscle involved is genioglossus. Okay, very good. ஸோ ஜீனியஸ்னா அடிக்கடி ப்ரொட்யூட் பண்ணி ஆன்சர் பண்ணுவார் எல்லாம். ஏன்னா அவருக்கு ஆன்சர் தெரியும் எல்லா கொஸ்டினுக்கும். ஓகே, டக் டக்குன்னு முன்னாடி வந்து பதில் சொல்லுவார் அப்படின்னு ஞாபகம் வச்சுக்கோங்க. ஓகே.
Okay.
Retraction of the
Mobility of the
tongue.
tongue is
Retraction of the tongue. What are the
styloglossus.
huh?
For retraction, styloglossus, sir.
Okay. Rotation of the tongue. Rotation of the tongue only, that is styloglossus, no? So style rotate பண்ணுவாங்க tongue. So the movie la kuda solluvaangala, macha rotate your tongue inside the mouth. Okay.
Okay, sir.
So styloglossus involved for the rotation of the tongue. Okay.
Okay, sir.
Yeah, proceed.
There is deviation of tongue to the right. Tongue appears pale, sir.
Okay, why you are asking deviation of the tongue to the opposite side?
Maybe due to some nerve involvement.
Okay. The tongue appears pale. Okay, when the tongue appears high colored, then because see what you are telling only I am asking question.
In erythroplakia, red visual field, sir.
Okay, in the erythroplasia you will have red colored tongue. Okay, very good, accepted. Then so before committing that malignancies regarding tongue, you have to tell what are the causes for the macroglycia.
Yeah, large abnormal large tongue, hemangioma, lymphangioma, neurofibroma.
Hemangioma, neurofibroma. Okay. Plexiform neurofibroma. Okay. These are all the causes for then lymphangioma. Okay, lymphangioma.
Okay, sir.
These are the causes for the macroglycia. Okay.
There is no fissures, and then the retromolar.
Wait. I have question for fissures. Okay, what are the types of fissures you will have in tongue?
In transverse and longitudinal, sir.
Longitudinal?
Longitudinal in syphilis we may get it, sir.
Okay, transverse.
In congenital fissures we will get transverse fissures.
Okay, in congenital you will have transverse. See the remember எப்படி remember பண்ணிக்கணும்னா syphilis will have long course. Okay, primary syphilis, secondary syphilis, tertiary syphilis. So you will have long course of disease. So longitudinal fissure is present in syphilis. Okay.
Okay, sir. Retromolar trigonus appear normal. Floor of the mouth appears normal, and hard and soft palate is normal. Anterior and posterior epithelium is also normal. Uvula
The
is in midline.
palate is normal. You are telling. So in case of oral cavity malignancy, hard and soft palate. What is that important point you are keeping in your mind, and you are telling that the hard and soft palate is normal?
One is for carcinomatic infiltration, another for gummatous ulcers.
Okay, you want to tell about that gummatous ulcer which is present in the syphilis, which may cause damage to the hard palate. Okay, very good. Then
Any carcinomatous infiltration in the nearby structure, so that's it.
okay, very rarely to get carcinomatous deposits in the hard and soft palate. Then see that you in the oral cavity examination you have to commit to tell about that cleft lip and cleft palate, and that the cleft lip or cleft palate is complete type or incomplete type, unilateral side or bilateral side. Okay, for those things you have to
Okay, sir.
come in that hard palate also.
Okay, sir. Anterior and posterior pillars appear normal. Midline, no tonsil enlargement, and posterior pharyngeal wall is normal. In palpation, it is not warm, it is tender. Inspector findings of size, shape, and extent are confirmed. Hot in consistency. Induration is present at the base of the ulcer, covering 1 centimeter around the ulcer. Induration is also present on the left side of the floor of the mouth. Ulcer is not mobile. It bleeds on touch. There is no mandibular thickening, sir.
Okay, why that induration is present in that where actually the lesion is present?
In left side of the tongue, sir, under surface.
Okay, why the induration is also present in the floor of the mouth? You are telling me, okay. Okay, how will you examine that induration of the tongue, induration of the mouth?
By keeping the tongue relaxed inside the oral cavity, we have to palpate and see, sir.
Okay,
Before palpating, we have to.
why you have to examine that inside mouth only?
Because if the tongue is protected, means the muscles is contract, so we may be falsely say that the ulcer is indurated, sir. So that we will keep the tongue relaxed by keeping it inside and palpate, sir.
Okay, very good. So, what is the importance of induration here, Pravina?
So that if the carcinoma gets advanced in corneal carcinoma, so that you will see the induration, sir.
Okay, so all carcinoma, yes, okay. Mainly that squamous cell carcinoma will have induration. Okay, agree with you. So, see that induction covering around 1 centimeter. You are telling why it is, why you are selling, why it's important for a clinical point of view.
But when you frozen tongue advanced to stage 2.
No, okay, you have to give margin clearance. No, for that purpose only, it is very important. Okay, for how much margin clearance usually you will give for tongue? And,
Or usually 1 centimeter or 2 centimeter clearance, based on the size of the ulcer, sir.
around 0.5 centimeters is enough for oral cavity, especially for tongue. Okay.
Okay, sir.
Okay. So the induration means the so locally metastasis up to that site. Okay. It's an indirect evidence. You should give margin clearance to that regions. Definitely, you should not leave the areas. That indirect area, you should not leave that area. Okay.
Okay, sir. Examination techniques, multiple district nodes of size 2 cross 2 centimeters is notable in right segmental, right upper jugular, and right middle jugular, and left posterior triangle levels. The lymph nodes are hard in consistency, mobile, and non-tender, and skin over swelling is normal, sir.
Malignancy, what are the lymph nodes involved in tongue malignancy?
Submental, submandibular lymph nodes, sir.
Okay.
And then jugular digastric lymph nodes.
Okay,
Upper
proceed.
deep cervical and pharyngeal lymph nodes, sir.
Okay, okay. So the lymph nodes are hard in consistency at which side?
On right side, sir, contralateral side.
Which level of lymph node is involved here? Skin over the skin is normal. Okay. Tell me which level of lymph node is involved.
Up to 5, sir.
Okay, so multiple discrete nodes of 2 centimeter palpably in submand. You're defining only submandibular lymph node only.
Yes, sir.
Or the lymph node is present in the level 3 and the level 4 also.
Yes, sir. Right upper jugular and right middle jugular also involved. So level 3 nodes also involved, sir.
Okay. But in the tongue malignancy, it's a very rarely spread to that level 2 and 3. Okay. If most of the time now the patient will not have any lymph node involvement. So for those cases, what you will do, Pravina? So you can do prophylactic homozoid dissection. Okay.
Okay, sir.
You may not have any clinical evidence of lymph node enlargement. For those cases, you should do prophylactic lymph node neck dissection. Okay.
Okay, sir.
Proceed.
Other systems examination, respiratory system, non-vesicular bed sounds here, and no added sounds. Serious S1 and S2 here, no murmur. Abdomen soft, non-tender, no organomegaly, no palpable masses, no free fluid, hernial orifices are free. CNS, no focal neurological deficits. Spine and cranium normal. Diagnosis: the carcinoma of tongue involving the left ventral surface of tongue with the TNM staging of T4A, M2C, M0, that is stage 3, and the involvement of 1A, 2, 3, and 5A levels of lymph nodes in the next.
Okay. So, tell me the TNM staging of tongue.
Okay. First, T1 means the size of the ulcer is less than or equal to 2 centimeter, but the depth of invasion is less than or equal to 5 millimeters. T2 means the size of the ulcer is less than 2 centimeter, with the depth of invasion more than 5 millimeters. T3 means the size of the ulcer is 2 to 4 centimeter, with the depth of invasion more than 10 millimeters. And then T4
Okay.
T4 means it is a moderate advanced localized disease, sir. The size of the ulcer is more than 4 centimeter and depth of invasion more than 10 millimeters, sir. With involvement of adjacent structures like mandible, maxilla, maxillary sinus, and the face of the skin, sir. T4B means it involves a pterygoid plate, skull base, and internal carotid arteries, sir.
Okay, which is not able to removable, non-removable structure. T4B is non-removable structure. Simply,
Okay,
okay.
sir. Okay, sir.
Skull. Okay.
Okay, sir.
And please, admin, make me as host. But I can edit something. I can write something. Okay, ma. How will you proceed this case?
So with the
Yes. How will you proceed?
total glossectomy with radiotherapy, sir.
You want to give total. You want to perform total glossectomy, is it? So immediately you are jumping to that treatment. You don't want to evaluate this patient.
Yes, sir. We have to do investigation.
Yeah, you have to confirm, even though it is a look like malignancy. You have to confirm
Okay.
the
To,
histopathology. Without histopathological evidence, you can't do the glossectomy. After you
okay,
remove glossectomy, if any some benign conditions like hyperplastic candidiasis, like that, if it comes ulcerated hyperplastic candidiasis, if like no, the patient will not speak, his lawyer will speak.
okay, sir.
Yeah, okay, because you did a total glossectomy, how can he talk? Okay, so you have to do histopathological investigation. What investigation you like to do for this patient?
Edge wedge biopsy, sir.
Okay, why you want to do that edge biopsy?
Because at the edge of the ulcer only there will be cell proliferation will be there, sir. So we have to edge biopsy.
What is the usual edge will be present here? How the edge look like, no? Because depending upon the how the edge look like, you will defining that ulcer, no? Please change me as to edit, ma. Please admit.
Rahul?
Please. Yeah. Okay. I got it. So edge, depending how the edge look like, you have to.
Averted edges, sir.
Yes, very good. Averted edge. Okay. When where you will have another edge is sloping.
And syphilis.
Where you will have sloping?
In syphilis, sir.
Syphilis or something else. Sloping edge. Yes, very good. Nandini, healing ulcer. Okay. Then another one is undermined edge. Okay. Where you will have undermined edge. Okay, Nandini, right. Tuberculosis. Okay. You. Hmm?
Okay.
Okay. Then another one type is punched out. Where you will have punched out ulcer.
In tertiary syphilis, sir.
Okay, gummatous ulcer. Very good. Gummatous ulcer. Okay. Then where you will have everted edges.
In carcinoma.
Yes, squamous cell carcinoma. Extremely right. Yes, squamous cell carcinoma. Everted edge you will have. Okay. Then where you will have rolled out edges. Yes, basal cell carcinoma. Extremely is right. Okay. So sloping edge, undermined edge, punched out, everted edges, squamous cell carcinoma, rolled out is in basal cell carcinoma. So depending upon that edge, you can tell. So what it is? Mnemonic is super. SUPER, super. Okay.
Okay,
So
sir.
that ulcer is a short note question. You can write that super. Sloping, undermined, punched out, everted, and rolled out. Okay.
Okay.
Okay, so you are taking edge biopsy. Then how will you proceed? So the edge biopsy is showing that the patient is having well differentiated keratin pills is present. So squamous cell carcinoma. Okay.
Okay. Hello, sir.
Yeah. Then what you will do? Now, what is the next step?
We have to see for USG, orthopantomogram, and CT scan and MRI we have to take.
Then you got to perform FNAC of the
FNAC
lymph node.
also, sir.
FNAC of the lymph node. It is very important because the patient
Okay.
having halitosis. That halitosis may be due to any infection in the oral cavity that may lead to that lymph node enlargement. But if there is a culprit, is malignancy is present, you should consider it is also a malignant deposit of lymph node, not infection. Okay.
Okay, sir.
Anyway, you have to confirm with the FNAC. Okay, USG neck is actually it will not give that much a reliable value. So you have to perform CT neck. Okay, CT neck.
Okay, sir.
So in that FNAC of the lymph node, what important finding you will look in that FNAC? One important point you should look. The important point is extra capsular extension. Okay.
Okay, sir.
Or not, because of the TNM staging is slightly changed, but it will not be asked in undergraduate level, but you must know. Okay.
Okay, sir.
Asked almost a advanced stage. Okay,
Okay.
so you have to look it for extracapsular expansion. Okay,
Okay.
why use the abdomen? What's the purpose of doing use the abdomen here?
Or to drain metastasis to abdomen, so to see.
Oh, no, very rare. See, you have to give clear in mind. See this the head and neck most common malignancy is head and neck squamous cell carcinoma. Okay, HNSSC.
Okay.
So this is the squamous cell carcinoma. This squamous cell carcinoma spread by what method? Lymphatic spread. So for the lymphatic metastasis, the important treatment what we will do is number one is resection. Number two is radiotherapy. Role of chemotherapy is rare. Okay, because
Okay.
the malignancy which is spread to the blood only, it will go to the other systems like abdomen.
Okay.
Okay, so in general squamous cell carcinoma will go like also like no 1 minute. So a squamous cell carcinoma will spread through the lymph node. So what we will do is we will do that radical surgery in that malignant part, and then we will give radiotherapy for the locally missed areas. Okay, that's the idea of. If example, you take example breast carcinoma, what you will do? These are all general concept, not related to your case. Okay, in breast malignancy, what you will do? You will
Biopsy.
you will do surgery.
MR.
You will give chemotherapy. You will give radiotherapy. Why? Because breast carcinoma have metastasis through the blood also.
Okay.
Okay, it metastasis to the dorsolateral spine. It metastasis to the liver. Okay, that's why you are giving adjuvant chemotherapy. Okay, for the tumor bed you are giving radiotherapy. These are all general concept. General concept means for the blood spread you have to give concentrate on giving chemotherapy. For lymphatic spread you have to give concentration on radiotherapy. These are small general points. Okay, example I will clear. I think you are not in clear. I will give another example. Stomach, what you will do?
Yes.
First you will do surgery. Okay, then what you will do?
You have anastomosis, right?
Okay, you will do resection and anastomosis. Then adjuvant therapy, what you will do?
Chemotherapy.
Yes, because why? Because it has blood spread.
That's it.
Yeah, that's why you have to give chemotherapy. Then what you will do? Also, if a tumor bed is present, recurrence present, you may give radiotherapy. But very rarely you are giving radiotherapy in stomach because of it is adenocarcinoma. Most common type is adenocarcinoma.
Okay.
This stomach malignancy is less sensitive to radiation therapy. அதனால நம்ம யூஸ்வலா கொடுக்க மாட்டோம், வெரி ரேரா தான் கொடுப்போம். ஓகேவா?
Okay.
These are all the general concepts regarding chemotherapy and radiotherapy. Okay, so chemotherapy blood spread இருக்குன்னா கொடுப்போம். ரேடியோதெரப்பி எப்போ கொடுப்போம்னா லிம்பாட்டிக் ஸ்ப்ரெட் இருக்கிற மாதிரி இருக்கிற இடத்துக்கு கொடுப்போம். அது சும்மா ஜெனரல், இதுதான் கிடையாது, இது ஒரு ஐடியா தான். ஓகே.
Okay.
Okay, why you want to do pan endoscopy? What it is? What you mean by pan endoscopy? What is pan endoscopy? You are written as pan endoscopy. Why you have written pan endoscopy? What is the purpose? Anybody in the group?
Yes.
What is pan endoscopy?
posthumous what of tongue posterior pharynx.
Okay. Now, my question is, what do you mean here by pan endoscopy? And why you want to do pan endoscopy here?
To also visualize the upper GE, sir.
So actually, I will tell the answer. Okay, pan endoscopy here means in the all mode of, it's not colonoscopy. Nitya, not colonoscopy. Upper GI endoscopy. Okay, very good. Anyway, good try to answer. Number one is pan endoscopy means you are visualizing in the all direction to look for any other tumor is present. Example, yes, to identify cancerization. Yes, very good, Ashika. Good answer. So upper GI endoscopy. So you will look the any metachronous, any synchronous lesion is present in the esophagus, in the stomach, or in the duodenum. Okay, number one. Number
Okay,
two. Number two is you will do bronchoscopy. Okay. Number three is indirect laryngoscopy. Okay. So in the
okay,
bronchoscopy,
sir.
also laryngoscopy. Okay. So to look for that airway, any lesion is present in that airway. Okay. Like in the trachea or in the larynx, any malignancy, any synchronous lesion is present or not. You have to look it. Okay. Okay, Prerna, then the
Okay,
question
sir.
is, what is a synchronous lesion? What is metachronous lesion?
Synchronization
And
means
ask,
the ulcer appears within the 6 months in the same site, sir.
okay. Ashika, is question for you.
Metachronous.
Can you answer? What is field cancerization?
Sir, carcinoma affecting the similar mucosa present in the body, sir, which is exposed to
Yes,
the
ma.
same risk factors.
Yes,
Synchronous
ma.
if the, sir,
Yes, ma. Yes, ma. Proceed.
synchronous if the carcinoma present within 6 months, sir. If metachronous after 2 years, if the carcinoma present is metachronous.
After, not after 2 years, 6 months to 2 years. Okay.
Okay, sir.
If more than 2 years means a second primary. Second primary. Okay.
Okay, sir.
So that the field cancerization is what it is. What she told is exactly correct. So the patient is, if example, the patient is a beetle net server. If she developed malignancy in the left side of the buccal mucosa, the carcinogenic agent which is responsible for the left buccal mucosa, okay, also the areas exposed to hard palate, soft palate, right buccal mucosa, trachea, sorry, esophagus, cricopharynx, retromolar trigon, all the areas exposed to the carcinogenic agent. Okay. Today, the patient is developed malignancy in the left buccal mucosa, but tomorrow the patient may develop malignancy in the right buccal mucosa or some other areas. Okay, so same carcinogenic agent exposed for the same period is vulnerable to develop malignancy. That is called field cancerization. Okay, got my point, Pravina?
Yes, sir.
Okay, proceed. We will have only we will have class 10 minutes only. Okay, so be brisk.
Okay,
I think all of you
okay, sir.
20. Come, 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 come. Okay, ma, you proceed. Proceed, ma. No, my dear. No, no, no. Please don't cry. Hey, okay. Okay, ma, proceed, ma.
Multimodality treatment, radiotherapy and chemotherapy, sir. Total glossectomy with the reconstruction of tongue using rectus abdominis reflux and modified radical diffusion of both sides, sir.
Okay, ma. So, what are the treatment options for carcinoma tongue?
We can do wide excision, sir, if it is less than 1 centimeter means. And then we
Okay.
can do partial glossectomy if it is 1 to 2 centimeters, sir. If it is more than 2 centimeter means we can do hemiglossectomy, sir.
So the surgery, according to you, surgery is the treatment of choice for the patient. Okay.
Okay.
So now I am asking that patient is lesion is around 1.5 centimeter. Growth is present in that anterior two-third of the tongue in the lateral aspect. Is actually a politician, is a leader in an important party. So he is refusing that I will not undergo any surgery because my voice is my vote. Okay, I will get votes.
Okay.
My life is my voice. He is not. He
Okay,
is
sir.
refusing to undergo surgery. He is not willing to undergo glossectomy. Then what we will advise to the patient?
Radiotherapy, sir.
Huh? What?
Radiotherapy.
Yes, radiotherapy. You can advise radiotherapy. Radiotherapy also equally effective in tongue malignancy. Okay, tongue
Okay,
carcinoma.
sir.
Radiotherapy is equally effective in tongue malignancy. Okay, so even though tongue malignancy radiotherapy is equally effective, you are telling that glossectomy is the treatment of choice. Why?
Because it is stage 3, sir, so that's
Why? Because of
the definition of a stage 3, sir.
okay, not about that in the stage 3 also. For generally, you will advise yes. Okay, Nandini is that the permanent cure. Okay, that radiotherapy is equally effective. Radiotherapy also is give permanent cure. What is that point added for the surgical view? That the surgery is the best choice. Age, okay, no, surgery is the best. Why surgery is best? So you have to differentiate. No, so surgery, Saloni for histopathological examination, very good. Vishwasari, we can take exudates biopsy also. No problem. You will get that. So in the radiotherapy, what are all the advantage of radiotherapy is that anatomical structure is intact. Okay,
Okay,
anatomical
sir.
structure is intact. That is the main advantage. Okay, advantage is equally effective in early stages. Equally effective in early stages. Okay,
Okay.
surgery, as you said, you are removing that tumor tissue, so the patient will have good thing. I excised the tumor tissue. Okay, you are removing the tumor tissue, but the disadvantage is anatomical
Yeah.
structure is modified.
Okay, sir.
Okay. But even though these are all the advantages and the disadvantages, the main advantage of advising surgery, example, if this patient is in the 50 years, you are doing surgery for the tongue carcinoma, you will have opportunity to develop any synchronous lesion, metagranous lesion at the age of 60 years. If he, because the field is cancerized, if he developed any buccal mucosa tumor, at the time you can give one more treatment option like radiotherapy.
Okay, sir.
Okay, but if you are giving radiotherapy in the first cancer also, if the patient is developed malignancy which is inoperable site like a cricopharynx or hypopharynx, okay, or near the
Okay,
vocal cord, if he developed malignancy, you can't offer surgery as surgery as yet. All of you got my point. You are treating the
yes, sir.
primary.
Yes.
If you are treating that first case, first tumor as a surgery, you have the opportunity to treat the patient for next malignancy by giving radiotherapy. But for the first lesion itself, you have treated with the radiotherapy. You don't have any weapon to treat if the patient is developing second malignancy in field cancerization area. Got the point?
Oh, okay, sir.
So the treatment of best treatment of choice is surgery, surgery, surgery. Okay.
Okay.
Okay. Okay. Then, so modified radical neck dissection of both sides. So what is called a modified radical neck dissection?
In modified
So
radical
you,
dissection, we can.
okay, wait. Before that, you tell me the stages of nodal staging. You didn't tell that nodal staging.
Nodal staging, N1 means the size of the node is less than 3 centimeter with extra nodal sections negative, sir. N1. And then N2 means N2A, N2B, N2C. N2A means single ipsilateral node of less than 3 centimeter with extra nodal extension positive, sir.
More than 3, sorry, more than 3 or less than 6 centimeter ipsilateral. Ipsi single. Okay.
Yes, sir.
Idla ipsi multiple.
Multiple.
3 to 6 ipsi multiple. N2C is more than,
6.
sorry, 3 to
Less than
6
6. E
bilateral.
negative.
Bilateral. Okay. N3 is
Okay.
more than 6 centimeter. Okay.
Okay.
Is these all are extra capsular extension negative? I told no one point. You have to look
Yes,
for
sir.
extra capsular. Oh, in all these things, extra capsular is extension is negative. N3 is 6 centimeter. Extra capsular extension is positive. Is N3C. Okay, got the point?
Okay.
So N3C is extra capsular extension positive. Okay, so you tell me about
Okay.
the MRND now.
MRNT means we have to spare at least one non-lymphatic structure, sir, like spinal accessory no, internal jugular vein,
Okay,
sternocleidomastoid, sternocleidomastoid, sir.
okay. What is MRND? Please clear it. Admin, please, Rahul, clear it. I'm not able to write. Okay. So
MRNT type.
MRND types. Tell me MRND types. MRND 1, 2, 3.
One means sparing of spinal accessory nerve, sir.
Okay. MRND 1 is what is
Sparing
preserving
of spinal. Yes.
spinal accessory nerve.
No.
Okay. Okay. Now
Two
MRND
means
2.
internal jugular vein, sir.
What is internal? What is it? Only you are preserving internal jugular vein. MRND 2 is spinal accessory nerve plus
Internal jugular.
sternocleidomastoid.
Okay,
Preserving
sir.
structures. These are all preserving structures. MRND 1 is you are preserving only one structure, that is spinal accessory nerve. MRND 2 is you are preserving two structure, that is spinal accessory nerve and sternocleidomastoid muscle. Okay. MRND 3 is you are preserving three structure: spinal accessory nerve, sternocleidomastoid muscle, then internal jugular vein. Okay.
Okay, sir.
So that is, I will give mnemonic for this. Okay. MRND 1, because this is the frequent question. Around 50 questions we will ask in this topic. In MRND 1, which you will preserve. In MRND 1, next question is, in MRND 1, what are all the structures you will remove? In MRND 2, what are all the structures you will preserve? What are all the structure you will remove? Like that, they will have different direction of questions. So it is very important topic. So I want to give mnemonic for this. Okay. In MRND 1 is first is you are preserving nerve. In MR and 2 is you are preserving nerve preserve muscles. In MR and 3 is you are preserving 3 structure: nerve, muscle, and vein. Okay.
Okay.
Mnemonic is 1 minute. 1 minute. N is Nanban. Okay.
Okay, sir.
In MR and 2 is Manaivi. M for Manaivi. Okay.
Okay.
3 is வீடு. V for வீடு. ஸோ ஒருத்தனுக்கு ஒரு பையனுக்கு வந்து லைஃப்ல வந்து நண்பன் தான் கிடைக்கும் ஃபர்ஸ்ட். ஓகே.
Okay, sir.
அதனால நண்பன். ரெண்டாவதா யார் வருவாங்கன்னா மனைவி வருவாங்க. நண்பன் பிளஸ் மனைவி. நம்பர் 3 வந்து அவன் வந்து வீடு கட்டுவான். ஸோ நண்பன், மனைவி, வீடு மூணுமே MR&3 இருக்கும்.
Okay.
நண்பன், மனைவி, வீடு என்ன இதுதான் வந்து நிமோனிக். ஓகே. ஓகே.
Okay, sir.
Okay. I think we will finish this session because of the clinical class. 1 hour is enough.
Okay. Thank you so much, sir.
Thank you, sir.
Yeah, all of you got. Do you have any doubts? Anybody have doubts? Okay, dear students, kindly give your review to my number, the personal WhatsApp number. Okay. Give me suggestion to improve me. Anything. Okay.
Okay, sir.
Points to add like that. Anything is there? Please tell me that I will improve myself. Okay.
Okay.
Thank you. All the best to all. Thank you. Bye. Good night.
Thank you so much, sir.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.